Good morning, and thank you so much. Welcome to our special training on traumatic brain injuries. This is hosted by the Indiana Coalition to End Sexual Assault. My name is August Maples, and I am the Training and Events Manager here at ICESA. Please be aware that this session might include triggering content, so please feel empowered to leave this session if you feel uncomfortable in any way. So, just a quick introduction. Brittany is a nationally certified forensic nurse and violence prevention coordinator at St. Elizabeth Healthcare. So, thank you so much, Brittany, for joining us today. We are so excited. We have heard that this topic has been requested by so many different advocates. There is a significant need for this. And so, we are just so excited to have you educating us today on this topic. So, thank you for joining us.
Thank you for having me. I appreciate it. I'm excited as well to get this information out and get people educated because this is definitely something very important that we should all be aware of. So I'm super excited and I do appreciate you guys having me. I guess we will go ahead and get started. So, as he said, my name is Brittany DeFilippo. I work for St. Elizabeth Healthcare. I am a forensic nurse, and I'm also my position in the forensic department is the violence prevention coordinator. So, with that, it is grant funded, my position, and we have a violence prevention coordinator on the department, and she mostly does like our northern Kentucky area. And so with this new position, my grant funded position, we're able to expand that a little bit outside of northern Kentucky. And my role is to be more engaged with the southeastern Indiana. So we did partner with Safe Passage for one of our projects. And what that looks like is me going into the domestic violence shelter there in Indiana. I go once a week and I do a lot of medical advocacy there, follow up exams, medical forensic exams. But one of the major key points that we started implementing was traumatic brain injury screening. So I do go in and I do scan clients who are at the shelter to see if they screen positive for a traumatic brain injury. And we've also worked with Safe Passage staff to be able to implement these screenings as well, because the screening tool that we chose did not need to be a medical professional screening. So that's how we've implemented that a little bit. But before we get into all of that goodness stuff, I'm just going to talk about what the forensic department looks like at St. Elizabeth Healthcare, who we are, what we do. I think it's important for people to know that we exist and we're out there and we're here to help. So, first, we're just going to talk about that and then we'll get into the traumatic brain injuries and screenings and all of that. So, as I said, I'm the violence prevention coordinator. Selena McCormick is the Northern Kentucky prevention coordinator. And then Jill Brummett is our nurse manager. So, what is a forensic nurse? I'm just a regular registered nurse, but I did go through extra specialized training and education to care for patients who have experienced violence. I am able to perform medical forensic examinations. We are trained in evidence collection. We can collect evidence given the situation, depending on what that looks like. And we're members of the multidisciplinary team, which we also create task force to try to get more team members on board. We work really well in the community with our partners, and we do a lot of education in the community as well. And because of the medical hearsay law, we are often called to testify in court if we do complete a medical forensic exam. We can also provide testimony in court as a expert witness in strangulation. I myself and Selena and Jill have all taken extra training to be able to testify as an expert witness in strangulation cases. So we do that a lot, actually, more than you would probably think. So our services at St. Elizabeth Healthcare are 24/7. Do it as an on-call system, basically. So if a patient were to come in and disclose a sexual assault, intimate partner violence, strangulation, family violence, human trafficking, elder abuse, or child physical abuse, we would go in and see that patient immediately. So our services are always available to this population. Our sexual assaults, we do over the age of 14. We do, if someone comes in younger than 14 years of age, we do recommend that they go to Children's Hospital just because we're so close to Children's, and Children has their own pediatric SANEs. So we just think that it's for the better of the patient, because they have more services specifically for pediatric population, that we do send anyone under the age of 14 to Children's, and they have the Mayerson Center over there for resources, and it helps that patient and that family throughout this whole process. But we will see anybody over the age of 14. We see all domestic violence and intimate partner violence cases, strangulation cases. We used to just see strangulation cases in the event that it was an intimate partner, but we had a lot of requests that strangulation was happening like on stranger to stranger assaults more often than they wanted. So we did just recently open that door to do all strangulation cases. So it does no longer need to be an intimate partner. We do family violence, and that can look like sometimes if a couple's not married, but they have in laws. So that family violence can be cousins, uncles, grandmothers, things like that, in laws as well. Human trafficking, we are consulted for a lot of human trafficking cases as well. Sometimes that can be on admission, they disclose something, or they come into the emergency room with lots of just red flags. So they'll contact us to go in and just talk to that patient and see if they will disclose anything to us. Elder abuse, and then like I said, child physical abuse as well. Sometimes with child physical abuse, we take that case by case. Kind of depends, like I said, back to the children's, being more specific to the pediatric population. If they're needing scans or x-rays, things like that, that may be better suited at the children's hospital, then we will recommend that they're transferred to children's. So we do mainly provide our medical forensic exams at our emergency rooms, but sometimes we see them as an inpatient on the floor. We do also get consulted to our local jails, and most of those are for human trafficking. If the jailers suspect human trafficking or that person discloses something regarding human trafficking, we will come into the jail and we will speak to them there as well. So, what does a medical forensic exam look like? First, we go in, we introduce who we are. We make sure that the patient wants these services that we can provide. It's very important to know that our services are not something that our patients have to do, but it's something that they're willing and able to do. And sometimes they may be willing to do it, but they're not able to do it in that moment. For example, if someone comes in and discloses that they believe they were sexually assaulted, and they believe that they were drugged. So if they come in immediately after that and they're still like kind of drowsy, falling asleep, things like that, then we may say, we can definitely do this for you, but we're just going to let you rest a little while and then we'll come back and revisit this. So they have to be willing and able to participate. So once all of that is completed and they tell us that this is something they want to do, then we move forward with it. And what that looks like is the first portion is a narrative history. So that's basically just letting the patient tell us what happened to them. It gives them the empowerment to speak about the events that occurred to them, and it gives them some power back in place to determine what they want to do with this forensic exam moving forward. We do a physical head to toe assessment. We look at the patient from head to toe and we don't miss anything. We look in eyeballs, ears, mouths, everything you can think of. If we find any injury, we offer photography. We can take pictures of those injuries and document those injuries as well. If they don't want the photographs, we're still able to document what we see on them. So even if it's just explaining what their injuries look like versus taking photographs of those. Evidence collection. In the event of a strangulation, we can collect neck and buccal swabs. And what that looks for is touch DNA on the neck. The buccal swabs are from the patient, and we just swab the insides of their cheeks. And then the other set of swabs is the neck swabs, where we're looking for that touch DNA. So we get DNA from the patient for a baseline, and then the other swabs, we're looking for DNA that does not match the patient's. And a lot of times we get hits on those for the strangulation. Other evidence could be like a sexual assault kit, a drug facilitated sexual assault kit in the event that they believe that they might have been drugged or they can't remember events of the assault. Then we will do a drug facilitated sexual assault, which we don't test in our hospital, but we send it to the crime lab, and the crime lab will then test their blood and their urine for all kinds of drugs that may have been used in the assault. We don't do it at our hospital lab because we don't test for as much as the crime lab does. So that's why we send it off to the crime lab so that it's tested for way more than what we can do at the hospital. Um, we offer testing and treatment, and that can look different, not just based on the assault, but if there's something else going on with the patient and they need medication for that, then we also will prescribe that for them as well. A huge part of our exam is safety planning. A lot of times, our patients have to go back to the perpetrator because it's not safe for them to leave in that moment. So we do a large amount of safety planning with those patients to, and it's case by case. We meet them where they're at and what their needs are. So that safety planning looks different for every exam as well. We provide resources and referrals. Ion Center in Kentucky is a domestic violence facility in northern Kentucky, and then Safe Passage is who we refer to on the Indiana side of things. But if you have resources that you could offer these patients, please feel free to send me that. We have a whole discharge folder that we will give our patients. We have an Ohio folder, a Kentucky folder, and an Indiana folder because those are the three states that we mostly see. So if you have anything at all that you'd like for us to add to our discharge folder for these patients, please reach out to me and I will definitely get that added into them. As many resources and referrals that we can give these patients, the more opportunities that they have. We are mandated reporters, so we will also work with the cabinet as well when we need to make a mandated report. Our documentation is very, very thorough, and like a sexual assault exam can take up to 6 hours. Then the other ones, because our safety planning is getting so much more in depth and detailed, our intimate partner violence exams can take up to 3 hours, sometimes longer. I mean, I've been with a IPV patient for 6 hours and we still didn't even complete an exam at that point. It takes a lot of time to sit down and connect with these patients first and then get them through the next steps, whatever that looks like for them. The purpose of our exams is for medical diagnosis, treatment, and safety. We are not investigative and we're not prosecution. We can do evidence collection, but while the exams may be part of the prosecution, it's not our role as a SANE nurse to be investigative. And it's not our role to determine if something happened. One of the most common questions we get if police are at the side of the bed after we speak to the patients are, well, do you believe them? Do you think that it happened? Well, of course I do. It's not my role not to. But at the same time, if a patient came in for chest pain, I'm not going to try to figure out if they're really experiencing chest pain. My job is to treat that chest pain. So if they come in with a reported sexual assault, I'm treating that reported sexual assault and giving the patient what they need. If people are treated in a way with dignity and respect and just being able to look at all their options and their choices that they're able to do, they're less likely to suffer from the psychological and emotional effects of the trauma that they just encountered. So that is what our goal is. It's always a beautiful day to believe our survivors. Like I said, it's not our job to be investigative or figure anything out. We're treating the patient for what they need in that moment, and we meet them where they're at. Sometimes it may look like they just need shelter and they don't want an exam. So then that's where we go. We work on shelter, we work on getting them a safe place to go when they're discharged. And then if that's all they want, then that's all they want. So we just make sure that we're giving them all of their options, all their choices, and the support that they need to make whatever decision is best for them in that moment. We love giving them back that power and control because in the event that they were just assaulted, that was all taken away from them. So it is our goal to give that back to them and let them know that they are in control of what happens to them moving forward when they're with us. So we do this for the safety and the healing of our patients. And typically I'll walk in the room and I'll just say, I'm here to make sure that you're safe and you're healthy, and you get to tell me what that looks like for you. So, intimate partner violence. Intimate partner violence is when one partner is trying to maintain power and control over another partner in an intimate relationship. This isn't just about the anger. It's not about just the physical abuse, which can look like hitting, slapping, using weapons, strangulation. It's not about just sexual abuse, which can be coercion, rape. It goes beyond just psychological abuse, the threats, the intimidation, the isolation, the manipulation, stalking as well. It can be unwanted attention or contact from an intimate partner that causes fear to that patient. So we do a lot of screenings in our medical forensic exams to see where the patient is at as far as danger. And we have a stalking assessment that is in our medical forensic exam. We have the lethality assessment that's in there. So we just try to give them all the tools that they can. And we know that IPV escalates. It escalates most of the time. So we're there to educate the patient on what their future may look like as well. And officers play a huge role in intimate partner violence because they are typically the first people that are in contact with our patients. So they play a critical role in making sure that that patient is safe and then also offering them our medical forensic exam as an option for them. So here's a couple just statistics. I hate statistics personally in this field because we all know that not a lot of it is reported. So with the statistics that we have, we all know that it's most likely greater than what it's actually showing because not everybody is reporting that this is happening to them. So every 60 seconds, 32 people experience IPV, which just means that by the time that this presentation is over and we are done talking for the day, 2,880 people have experienced IPV. And these numbers on here are the national average for intimate partner violence. So the national average for women is 58.9 that are experiencing intimate partner violence in their lifetime. And men experiencing intimate partner violence is 27.9. Indiana is ranked number 5, and not in a good way because of the domestic violence that's happening in the state. So Indiana doesn't do so well in the domestic violence, and that's just because lack of awareness. People don't think that these things are happening in their own communities, in their own neighborhood, to their neighbors. So it's very serious and it's happening way more than we would like. 1 in 5 homicides are killed by an intimate partner violence. Sexual violence is a sexual act that is committed or attempted to be committed by another person without freely giving consent. So a person must understand what they are agreeing to and have the ability to make that decision without being pressured or any sort of impairment. So in the state of Indiana, consent is invalid if the person is under the age of 16. So a person under the age of 16 cannot give consent for sexual involvement. If a person is asleep, unconscious, or too intoxicated, then that their consent is invalid. If a person has any mental disabilities that affect their understanding or cognitive behaviors, they are not able to give consent either. And then if a person is threatened, manipulated, or coerced into having sex with somebody, that is also not consent. So in the state of Kentucky, we can collect that sexual assault kit 120 hours from the time that the assault occurred. Sometimes we run into the event that it's like, well, she just got here. It's been 125 hours since the assault. We may go and collect that kit anyway, just with that possibility. If it's so close to that timeline, we will consider it. And then actually in the state of Kentucky and Ohio, it's actually 96 hours. So it's only 4 days in Kentucky and Ohio. So Indiana does offer a bigger window, which is great. Non-fatal strangulation. So strangulation is when there is any sort of external pressure applied to the neck. So our neck is a huge part of our body that sends blood and oxygen to our brain and then back to our heart. So any amount of pressure that is applied to the neck can slow down or completely stop the blood flow or the oxygen to the brain and to the heart. So strangulation is actually the most lethal form in intimate partner violence. And what happens when someone's strangled is, like I said, it stops that blood flow, stops that oxygen, which can cause an anoxic brain injury. So it is definitely the most lethal form. And we are seeing this a lot, a lot, a lot. So it's very unfortunate. We do the strangulation kit, which I already talked about, the neck and buccal collection. We will measure the patient's neck circumference at the time of the exam, and then we will do a follow-up with them 3 days later to check that neck circumference. And what we're looking for there is their neck circumference on follow-up to be either the same or smaller, because in the event that that neck circumference is getting larger, then that means that there's internal swelling, or there's swelling, so something internally is going on if we can't see anything from the outside. We do have a specialized evaluation in our medical forensic exam. We have a whole strangulation assessment where we talk about different symptoms that they're experiencing, at what point in time during the assault were they feeling these symptoms, and if they're still experiencing those symptoms as well. We do follow the Training Institute on Strangulation's guidelines when it comes to strangulation, and they recommend a CTA of the head and neck be completed. And what that's looking at is the internal organs of the neck. It checks the muscles. A lot of times when a patients are strangled and they're trying to get out of that, they can tear their muscles, which can cause bruising, but cannot cause bruising at all. So, with our strangulation, sometimes they'll have a ton of injury and their neck scan will come back negative. We've had patients that have zero external injury, no injury at all, and they've had a tear and had to be put on blood thinners to prevent a blood clot from happening and going to the brain. So these strangulation cases look very different as well, but we do like to do that strangulation assessment that we complete on each patient that's been strangled because often the history and the symptoms that they're experiencing tell us more about the physical findings. And that's what we want to be looking for. This is the imaging recommendations for that TTA of the head and neck. And that's from the Institute on Strangulation. Human trafficking, the exploitation of men and women and children, and this can be in different forms. So it can be labor trafficking and it can be sex trafficking. Anything by a third party for profit or gain. And these cases are often the hardest, I think. It's hard to get someone to disclose it, mostly because the trauma bonding. Trauma bonding is a real thing. These survivors form a strong emotional attachment to their abuser. And this bond develops over cycles of abuse, but with intermittent kindness from their trafficker. So it makes it extremely difficult for these patients to leave, to seek help, or even disclose that anything is happening to them. So technology has also made this recruitment much easier. It's more discreet, and they're targeting younger population here as well. But human trafficking goes beyond like the white van that you see driving down the street that stops and picks up these children, or from another country and they're loading children on a plane and bringing them over. That's what it appears in the movies and things like that. But these are happening in our backyard. These are happening in our communities, in our neighborhoods. And most of the time, their trafficker is someone that they know, someone they trust. A lot of times it's a mother who is struggling and sells her children to get by in life. So it's very sad. The amount of profits that human trafficking makes, whether it's labor or sex, is out of this world. In 2024 was populated that 236 billion were made in 2024 from illegal profits from human trafficking. So this is a huge problem that we have right now. Some medical advocacy is something also that we provide. And this is more pertained to the shelters. In Northern Kentucky, we go to the Ion Center, who is a domestic violence shelter in Northern Kentucky. And then, like I said, in Indiana, it's Safe Passage. I go to Safe Passage once a week for a few hours, and they have a little office set for me. So I go in my office, I set up my laptop. Everybody knows I'm there the same day, the same times, and they can pop in and just update me. A lot of times it's therapy sessions with us, but we just talk. We talk about what's going on in their lives. I get them connected with primary care providers, eye doctors, pharmacy access. Their whole world has shifted and changed, and now they are living in a domestic violence shelter. A lot of times away from home, away from loved ones. So that means away from their prescriptions, their pharmacy, their primary care providers, and any specialized physicians that need to be looking at them as well based on the assault and based on their injuries too. So I follow up with them. And this is also a time if they've not had a traumatic brain injury screening that I will also provide this screening as well. So that's what our medical advocacy looks like in the shelters. And we'll get more into the TBI screening here in a little bit. These are some training and education opportunities that the St. Elizabeth Forensic Department offers. We do a lot of this in our community, but I wanted to make you guys aware also in the event that you or anybody in your departments or facilities may want or be interested in. You can contact me at any time and we can get something worked out. We offer the SAFE training, which is for a registered nurse to become a SANE nurse. So we offer that every year. We might be starting to do that twice a year, but we for sure do it once a year right now. We're trying to do one in the spring and the fall. Actually, in a couple weeks, we have another one coming up. So if you have anybody interested in wanting to become a SANE nurse, please let me know and we can get them registered for that training. We do strangulation training and education. We mostly do this with like our law enforcement in the area, prosecutors, things like that. We work hand in hand with the prosecutors as well, like I said, with that expert witness testimony or if we've completed an exam. So we do a lot of education with our community partners on that and traumatic brain injuries, the neurobiology of trauma, Trauma informed care. How do we take care of these patients? What's the best way to take care of these patients? They need extra focus and support. So we teach the trauma informed care. Forensic nursing 101. What is a forensic nurse? What do they do? And like I said, we're able to testify in court with that medical hearsay law. A fact witness is when we've seen that patient and we are the ones that completed that exam. So we are able to speak to that exam in court. And a lot of our documentation, we put our patients' words in direct quotes, and we are able to say those things in court, which is super powerful for a jury to hear as well. And the expert witness is on that strangulation. If you ever need to get a hold of a forensic nurse or someone in our department immediately, our St. Elizabeth Dearborn Emergency Department always has whichever forensic nurse is on call. So if you want to speak to a forensic nurse in that moment, please don't hesitate to call the emergency department. And they can contact you. They can give you our personal cell phone numbers, or they can transfer the call to us. So we're always on call 24/7. So no matter day or time, if in the event you're like, oh, what did that forensic nurse say? You can always call and be connected to one of us, and we can chat through it. If you have questions, if you just want to work through something, whatever, please don't hesitate. And that number on there is that the Dearborn Emergency Department's number. So please call them if you need anything from us. So this next part is going to be about the traumatic brain injuries, the concussions, the screenings, what we're doing with the domestic violence shelter in Indiana. And there's still a lot more work that needs to be done. And we're well aware of that. But this is the start of it, right? Like making sure people are educated on the importance of this. So that's why we wanted to discuss this today. So our objectives are to recognize the occurrence of traumatic brain injuries in the event of intimate partner violence, the different types of traumatic brain injuries that occurred in these patients. We want to recognize the signs and the symptoms of a traumatic brain injury, conducting a thorough medical forensic exam with consideration of the traumatic brain injuries. And then what are our survivors being challenged with when they do get this screening and they are positive, and what does that follow-up care look like for them? Because it does us no good to screen if we're not going to also be able to provide follow-up care. So again, this is our team, me, Selena, and Jill. I did add Miss Aloya Kramer to this as well. Aloya Kramer is one of the sports medicine doctors in our area here in Northern Kentucky. She sees like student athletes who are screened positive for concussions. So she sees a lot of the school athletes in the area, football, basketball, volleyball, things like that. So when we were deciding that we wanted to start screening for these TBIs, like I said, it does no good if we're screening them saying, hey, you might have a TBI, but then what do we do with them? So Jill and Selena and myself had a meeting with some of the doctors in our area and asked if they would be willing to see any of our patients, which we don't charge for. So that was a little difficult. We didn't have any takers. And then like 10 minutes later, Dr. Kramer reached out to Jill and said, I have to do this. So she is very sweet and she will see all of our referrals that we send her way. So we screen in the shelters at Safe Passage Shelter and then our 2 shelters in Northern Kentucky. And then we're also screening all of the patients that we see for our medical forensic exams. And Dr. Kramer and her team make sure that they see every patient who screens positive. So she has been a great addition to our team and she is so helpful to these patients. I have patients that will not believe me when I say, well, okay, well, now we need to get you set up for a follow-up for your traumatic brain injury with Dr. Kramer. And she's like, I just can't believe that so many people want to help me. Our patient population is not used to this, which is sad in itself, but it's so great and so rewarding that we're able to offer these services to them and let them know that there are people out here in this world who care about the things that are happening to them. So super powerful. Head injuries occur as a result of IPV. We know this. They're kicked, they're punched, they're pushed back, they hit their head on a counter, on a wall. They're strangled, so they're losing oxygen to the brain, which can cause a TBI. TBIs in this population are so common, but they're also very commonly missed. So that's why, as a forensic nurse, we are in such a unique position to be able to screen and recognize the potential for an acute TBI. And I'm not asking you guys to go out and complete these screenings and think, well, I'm a nurse now, so I'm going to do this screening. We're not diagnosing, and that's important to remember. We are not diagnosing a traumatic brain injury. We are screening them in the event that they may have a TBI. And then that's when they follow up with a medical provider who will either confirm or deny that. So it's very fortunate that we are able to recognize these acute brain injuries in this population. But again, it's important to know that we're not necessarily diagnosing them with them. We're just giving them the tools to be able to go and treat this in the event that they do actually have a traumatic brain injury. And something that we've learned is to always ask about head injury and strangulation. If we're not asking the right questions, we're not going to get the right answers. Concussions and TBIs affect brain function. They don't affect the structure, so they don't often show up on imaging like a CT scan, which is why the screening for TBIs is so important. Symptoms can be delayed. They can appear minutes, hours, days after the injury. One thing that I hear a lot when doing these screenings, we do ask about loss of consciousness in our exams, but if the patient does not think that they lost consciousness, A, doesn't mean that they didn't, but B, doesn't mean that they don't have a TBI because they did not lose consciousness. I've had law enforcement tell me, well, she didn't lose consciousness, so she's fine. That's not really the case. You do not need to lose consciousness to have a traumatic brain injury. Repeated concussions and TBIs can lead to long-term problems such as memory loss, mood changes, or CTE. So that's why it's important that we get on the ball with this. Here's a couple more statistics with intimate partner violence. I believe we talked about those already. 20% of all violent crimes are from intimate partners. That's a lot of crimes. There's a lot of violence in this world, unfortunately. But 20% of all violent crimes are from an intimate partner. And though it's more likely for women to experience intimate partner violence, these numbers highlight that the domestic and sexual violence in both women and men are at significant rates. And like I said, I don't like statistics just based on we're not really getting accurate numbers. But the numbers that we do have are high enough. So, and like I said, Indiana is ranked 5th highest for intimate partner violence out of all the states. And Indiana was actually, and I'm not hating on Indiana, but this just is that we need to get this awareness out. We need to educate. We need to work together to try to decrease these numbers. But in 2024, Indiana was the only state to receive an F rating, like ABCDF rating. And that was determined by the high domestic violence rates, the limited legal protections, and the severe shelter shortages. So it was one of the most challenging states for a survivor to live in. 95% of shelter requests went unmet, which means there was a lot of people that were needing a safety place, resources, and 95% of that went unmet because we don't have the resources. So it's super important. Again, I'm not bashing Indiana in the slightest. I'm just saying we need to work together and see how we can prevent these things from happening. And that's why we're all here today. A concussion is a brain injury. All concussions are serious. If we're not addressing them and they don't heal and there's repetitive concussion after repetitive concussion, that's going to lead to very long-term damages for this patient. They often go undiagnosed because you'll see here, it might be the next slide, the symptoms, it might be a couple slides, but the symptoms that you experience from a traumatic brain injury can look like anything. So that's why screening and asking specific questions related to the head injury are important because they go undiagnosed. This patient came in, went through this assault from her husband, and of course she's not remembering things. She's super stressed. She's shaking because she was scared. All these things can often be passed off as something else when in reality it's from a TBI. So we just need to recognize it and then give the proper response to it and get them the treatment that they need. It is an insult to the brain from an external force. It can lead to temporary or permanent impairment of anything, physical, cognitive, psychosocial functions, any of those things. So your brain works a lot of parts of your body, your whole body. So it can range from very serious to not serious at all. And it could lead to temporary to you'll never regain that function again. So, like I said, they can range from mild to serious and sometimes result in even death. So we just need to make sure we're getting to the bottom of it and figuring out what's going on. So that external hit to the head is it can be in this population a fist, an object. He could throw a frying pan. Someone could hit a frying pan over someone's head. Well, that's a blow to the head. Smashing them against the wall. If they're pushed and they're shoved and they fall back and they hit their head on the countertop. Anything that is a hit to their head, they hit their head in any way, shape, or form. That's a blow to the head. Another thing that we're looking at is the skull moving inside of the brain. And this can be shoved up against the wall, could be the perpetrator taking the patient and just shaking them severely, and that shakes their head back and forth. That can cause a TBI. The strangulation, like I said, loss of oxygen can come from the strangulation, can come from smothering, waterboarding, whatever the perpetrator is doing to obstruct the airflow or the blood flow will cause loss of oxygen, and then that can also create a traumatic brain injury as well. So here's the symptoms: headache, nauseous, vomiting, balance problem, they're dizzy, their sensitivity to light, they're irritable, they're depressed, they're anxious, difficulty falling asleep, they feel like they're in a fog, difficulty concentrating, difficulty remembering. So these are all non-specific symptoms, right? Which is why the screening is important, because it narrows down when these symptoms happened. Was there a head impact, and at the date and time? Because if these symptoms were happening before that, then they're probably not related to the head injury. If these symptoms happened since the head injury and are progressively getting worse, it could definitely be from that head injury. Doesn't mean that it for sure is, but it means that there's a possibility that it could be. And then that's why we need to address it. And all because they're appearing with these symptoms as well doesn't mean, again, that they completely are positive for a traumatic brain injury or a concussion at that point. It just means that we checked these boxes and you may have a traumatic brain injury. So, how we tell our patients to cope with this, how to manage these symptoms that they're having, we tell them quiet areas, dim the lighting on your phone, on your laptop, rest and take breaks. Don't get on your phone as much. Put your phone down. Don't go to work tomorrow. Don't go to school tomorrow. We'll put you off school for a week and then we'll reevaluate. Try not to read too much, because then that can cause the headaches and the confusion. Stress management and pain management. Pain management, we want them to obviously take care of their pain as well. Sometimes with TBIs, they have that pressure in their head, more like a migraine versus a headache, but we also want to treat that as well, too. So challenges. So we give them this whole list, right? Like, don't fill out paperwork, put your phone away, just sit in a dark room and just try to relax. Like, they just went through some traumatic events in their life. And most of them, especially at shelter, are trying to get into shelter. They're trying to take care of all the intake paperwork with shelter, trying to keep their kids in line too, and trying to keep their life normal. We're asking them to fill out these paperwork. Who can we speak to? Who can we not speak to? Do we need to get you into a doctor? What doctor do you want to see? So we know that we're asking these survivors to do all these things, as rest and don't do this and don't do that. But then at the same time, we're turning around and saying, okay, well, I need you just to read this and sign it real quick, and then we can be done. So it's really hard for survivors to follow our symptoms management form on things to do. A lot of times we will say, I think you should be off school or you should be off work for at least a week, and we'll reevaluate. Well, a lot of times they just moved out of their home. They have their children with us and they need to work. And if they don't work, there's going to be no income. So I would say that's probably the most challenging for our survivors, is we want them to kind of take a chill pill for a second and try to let that brain heal. But in reality, they just went through all of this and their brain, they cannot just put on pause. So it's a lot of talking and trying to figure out what works best for that patient in that time. So 94% of injuries are related to intimate partner violence, are from the neck and higher. So 94% of the time when someone is injured by an intimate partner, it's from the neck or higher, which means that there is head trauma happening over and over and over again, and we need to make sure that we are addressing it. It's estimated that the number of women who experience TBIs is 11 to 12 times greater than those experienced by military and athletes combined. And I don't like that this is specific to women. This whole slide is specific to women. There's not a lot of data out there. There's especially when it comes to intimate partner violence related to TBIs. So again, I just want everybody to know we know that this happens to not just women, right? But because of the information that we have is so limited, that this specific slide was just related to women, but we know that it's everybody. It's not just women. So 75% of female IPV survivors suffer at least one brain injury, and then 50% have repetitive TBIs. Again, this is why we came up with the plan to go into our shelters and to screen for TBIs for this population because they need help. Some barriers is a lack of awareness, and that's among healthcare providers. We are constantly going into our emergency departments or different departments in our hospital and educating. First, it was strangulation. Strangulation was so important, and we needed to follow these steps, these recommendations, and it was so hard to get everybody on board. I feel like we've come a long way with the strangulation. So now we've moved on to traumatic brain injuries. So it's about us getting the word out there, educating everyone who can be in contact with this population, and making sure they understand that this is serious. Our survivors, we need to educate our survivors too. They're not aware that these symptoms that they're experiencing could be caused from a traumatic brain injury. If we're not asking them where you hit in the head, they might not think that that was important because it may happen to them all the time that they've normalized it. So if we're not asking the right questions to our survivors, they're not just going to come out and say it. A lot of times they'll just answer yes or no. So that's why we just need to make sure that we're asking specific questions related to head trauma and related to traumatic brain injury symptoms. Survivors are scared. They don't seek help. 20% of survivors seek medical care for head injuries. So a lot of our intimate partner violence survivors go undiagnosed because they're not seeking medical treatment from the jump. So that's why, again, it's important that we're out there and we're educating our law enforcement who are usually first on scene when it comes to IPV. So we need to make the awareness so much greater than it is right now. Long-term effects of traumatic brain injuries: depression, chronic anxiety, sleep disorders, PTSD, cognitive decline. And that can start off very simple and could decline over time and never get that function back. There was a study done that increased dementia is linked to traumatic brain injuries and CTE. Obviously, we hear CTE a lot in professional athletes, but we're also going to talk about the difference between athletes and a survivor of IPV. And I think you'll see that CTEs might be a little bit more common in our IPV population. It's estimated that 31.5 million women in the US have experienced at least one IPV related TBI, and then 21 million have experienced repetitive TBIs from IPV. Those are a little bit more specific than the previous slide, so I wanted to throw that in there. So why are we missing TBIs in this population? Again, the awareness, it's not there. It's not there for medical professionals, law enforcement. It's not there for our survivors. If we're not asking the right questions, they're not just going to tell us. Our patients can assume that their symptoms are just from being stressed from this traumatic event that they just encountered, or the stress of trying to figure out what they're going to do with their children now. How are they going to get to their job? They just left their home. Maybe they left their pets. Maybe they had to leave their vehicle. So there's so many other things that they can push off that these symptoms that they're experiencing are related to. It's also assumptions that their symptoms are caused by something else by medical providers. I've had patients come in shaking, like their hands are trembling, they're shaking, their whole body is shaking. And a medical provider has told me, oh, well, they're coming off some sort of drug, like they're fiending, like they're withdrawing. A lot of our patients will use drugs and alcohol to cope. So that may be something that's happening, but we just have to look at the bigger picture, the whole picture, not the bigger picture, the whole picture. Yeah, they might be using drugs. They might be using alcohol. I'm not here to tell them whether they should or shouldn't, but I'm here to get them healthy. So let's address that. But then we're also going to come back to their symptoms and make sure that they're not related to a TBI. More acute symptoms are the focus. If you have a patient that comes in and was hit in the head over with a hammer, and they have a laceration to their head that needs cleaned up, needs staples, those are going to be addressed first. And a lot of times, emergency rooms aren't quick. We all know that. So a patient can be there forever and they finally just got their head stapled. Well, now they have to leave because they have to go pick their kids up from school. They're not going to stay and wait for us to complete all these things. But the main symptom, the main complaint was that they were bleeding all over the place, and now that's stapled and closed and they're not bleeding anymore. So they're ready to go. So again, it's just education and trying to complete everything that we can in a timely manner. Sometimes mild TBIs and concussions can resolve within 3 months. So our population typically will deal with injuries and abuse for a while. And if that's their norm and they're used to that, they just deal with the symptoms. They deal with the symptoms, and 3 months later, they're gone. And they're like, "Oh, not a big deal, right? Like, I couldn't sleep, I couldn't focus, I couldn't do this, but now I'm better 3 months later. So it doesn't need to be addressed." What do we see here? What is this guy? Anybody? It's a real easy question. Anybody knows what this guy does? Come on, guys. He's a football player, right? So we have a football player on this side. He's getting checked out by a provider, right? He was probably hurt on the field, hit his head, and so now they're pulling him in to do all these things. This side, we have a patient. She experienced intimate partner violence, right? She looks a lot more beat up than he does. He doesn't look like he was really injured at all. The NFL has a 19-page protocol to prioritize player safety, right? Over performance. So when a football player is hit on the field, hits his head, whether that be collides with another player, gets pushed down, hits his head against the ground, whatever. He had any hit to the head, blow to the head, right? That's what we're talking about. He gets pulled from the field immediately. They go to the little tent, someone observes him in there, and then they go underneath the stadium into their more medical offices where he gets scan done and make sure that there's nothing internally going on too. If he screens positive for a possible TBI or concussion, he's pulled from next week's game. He is told that he has to rest with light activity, but with supervision. He can do, after a week, he can do light cardio with medical supervision. He can opt to do no contact drills, but there also needs to be medical supervision with him on that field. And by the time all of these go on, he is then cleared by both the team physician and then also an independent neurologist who clears him of having a concussion or TBI. And if the NFL does not go through with all of these steps, they're fined for $150,000. But when this patient comes into our emergency room and has disclosed that she suffered intimate partner violence, we make sure that A, she's not bleeding anywhere. And if she is, we're going to address that first. We get her a medical forensic exam. And this is prior to the TBI screenings, okay? So prior to TBI screenings, we complete an exam on her. We get her the resources that she needs. She's going to go home. So we safety plan with her on what that looks like for her to go home. And then she goes home. And that's that. We don't send medical supervision with her. We don't ask her to just do light duty and have a medical supervision with you at home while you sleep. And then the next day, we're going to go through these tests with you to see how your brain's functioning, how your balance is, things like that. We just send her on her way. So it's super important to realize that we're prioritizing player safety. And I 1,000% respect that, and as we should. But we also need to prioritize the safety of our patients. And that's why we are screening for TBIs. This football player had a helmet on, and the whole thousands and thousands of people saw it happen. This patient did not have a helmet on, I can tell you that, and didn't have people around her to tell her exactly what happened. If she blacked out for a minute, she's going to have no clue what happened. If he blacked out for a minute, you're going to have everybody on that field that's going to be able to articulate what exactly happened. Did he twitch? Did he seize? Or did he just lose consciousness? We can't answer those questions for her because she was alone with her perpetrator. So I like to do the side by side. I know it's hard, but when I teach this, I just want the severity to be out there. I think we don't really fully understand until it's thrown in our face like this. So that's why I like to do these side by sides. And also the NFL does have these guardian caps now. I don't know if anybody has seen them. I think they have to wear them in practice, but games are optional. They're just like a soft shell pad over their helmet that they wear, but it's engineered to absorb and disperse the impacts that their head gets throughout the whole helmet. So anyways, it lowers the force that's transmitted to their skull and to their brain. So we're making all these steps for our NFL athletes and all of that, but we're slowly trying to get steps for our intimate partner violence survivors. So there was also Stephen Casper and Kelly O'Donnell wrote an essay that just explores how gender influences the recognition and treatment of brain injuries in two distinct populations. So in this essay, it was professional boxers and a survivor of domestic violence. And basically what it does is it highlights how the social norms and gender roles are shaping the medical understanding and response to brain trauma. Men athletes are seen as victims of physical trauma, whereas female survivors of intimate partner violence are misdiagnosed with psychological disorders because they can't cope. They're not coping well. So they're saying a boxer who has head injury, well, of course, that's from physical injury. But a survivor of intimate partner violence is considered emotional trauma because they went through so much. They're stressed. So that's the difference here that Stephen Casper and Kelly O'Donnell pointed out here. So it just urges us to be more equitable, to be more trauma informed, and it calls for just trauma informed approaches and recognizing and treating brain injuries in survivors of intimate partner violence. So our intimate partner violence survivors are very unique and they're complex. When we see that NFL player, he hit his head once, right? He hit his head once, they pulled him immediately, and he gets all these tests and scans and all these things completed, where our intimate partner violence survivor has had multiple head trauma in just one assault. So they're kicked, they're punched, they're pushed up against the wall, they're pushed on the ground, they've hit their head in 3 different spots just in those 3 events. Their head slammed on the floor of the wall. They were shaken, so they got whiplash. Their skull or their brain was moving inside their skull. And then throw strangulation on top of that when we're giving them no blood, no oxygen to their head and to their brain. So it's very unique. More about the screening tools. There is not one screening tool that is specifically rated to address intimate partner violence related TBIs. So there's not one screening tool that is out there that is specific to intimate partner violence. More tools are designed for sports. Like Dr. Kramer, she typically does sports medicine. So there's definitely tools out there for sports and specific sports. There's one for NFL, there's one for soccer, there's one for volleyball. So there's more specific screenings depending on what kind of sport you're doing. Diagnosis and management is outside of the scope of the forensic nurse. So again, we're just screening that patient. I can't diagnose somebody because I am just a nurse. So I have no ability to diagnose somebody. And same for our advocates. They are not able to diagnose a survivor with anything medical, and neither am I. So what I'm doing is I'm screening. I'm asking you these questions to specifically screen to see if you have the potential to have a traumatic brain injury. So we thought, what tool can we use that can relate most to intimate partner violence? And there was a study done. There was a few different methods and questionnaires and screenings, but the one that we decided to go with all of us as a team worked on this, and we decided to go with the HELP screening tool. So there's no standardized assessment tool for brain injury after an intimate partner violence, but this is the one that best suited our population. So the HELP's brain injury screening tool assesses an individual's exposure to, again, a potential brain injury. It's simple to administer. You don't have to be medical personnel to administer this screening, which was another reason why we picked this, because we're going into the shelters. And a lot of times, if they've not had a medical forensic exam and they're just going straight into the shelter intake staff is going to be the one that is completing this screening on them in the event that we like to catch these as soon as possible. So as soon as possible is when they're coming in originally. So that's on intake is when these screenings should be done if they've not already been seen by my team and we've not already administered a screening on them. It clearly does not replace a face-to-face evaluation with a trained professional because, again, non-medical personnel can assist in these screenings and we're not diagnosing. We're just screening for the possibility. This is the HELP screening tool. So we did add on here and I didn't realize, so I apologize. At the top of this, we do ask the date, and the time of the assault. So we do these screening tools on acute injuries. So if they have had a head impact in the last 72 hours or 3 days, they are getting a screening tool completed on them. So we did add at the top like the date and time of the assault so we can determine if they even need this screening. So if it's been within 3 days, then they will do the screening. Now, in the event that they have had impact to their head and it's been over the 3 days, we can still complete this. And at the end, if they screen positive, we will send them to an adult neurologist because our Dr. Kramer, who works with us, sees them in acute settings within that 3 days of head trauma. She sees them acutely. If it's not acutely, meaning it did not just happen within 3 days, then they need to follow up with an adult neurologist. If they're still having symptoms and they screen positive, then we need to get them referred to an adult neurologist. And a lot of times when I'm referring these patients to an adult neuro, they do not need anything from us like an official referral. They're just able to call and say, "Hey, I was screened for the possibility that I have a TBI and they told me I needed to follow up with you," and then they get them in. So, but in the event that it's been the 3 days and it's an acute injury, we are still going to ask these questions. So, have you been hit in the head? Yes. Were you seen in the emergency room by a doctor because of the injury to your head? I will say this question I ask a little differently because we know this population doesn't always go seek help. So I will usually say, were you seen in the emergency room or should you have been seen in the emergency room from the injury to your head? Did they lose consciousness or were they dazed or confused or in a fog? So again, they don't have to lose consciousness, but if they did, then it's definitely yes. But did you feel like foggy, confused, like just kind of dazed? And then do they have any problems since hitting your head? So these are the symptoms: the headaches, the dizziness, the difficulty reading, writing, problem solving, sleeping, concentrating. So those things. And then any significant sickness, stroke, seizures. There's a couple things listed on here. The main thing that we see here for significant sickness is strangulation. So we added strangulation to be a significant sickness because much like the stroke and the seizures, it's all brain activated and functioning. So with strangulation, it cuts off that blood flow and that oxygen. So that's why we felt it was significant to add it here. So if any of our patients disclose that they were strangled during this assault, we automatically will answer yes to any significant sickness. And then we'll just make a comment that patient was strangled. So they have to answer yes to 3 questions to screen positive. 1, if they hit their head, or were seen in the emergency room, or should have been seen in the emergency room, or significant illness, the last one. And they have to have 2 or more of the symptoms for it to be considered positive. So if your patient answers yes to, and I say patient, I know all of you, they're not patients. It's just, it's habit for me to keep saying patient, so I apologize. But if you guys have any of these clients, or whatever word you use, I'm sorry, they have to have 2 or more of those symptoms. So if they just say, well, I'm anxious, but nothing else, then it wouldn't be considered a positive screening. And this can look super scary. A lot of my forensic nurses will ask me questions every time they do a screening, and I am A-okay with that. In the event that you're in doubt whether the answer is yes or no, always put yes. We always want to err on the side of caution. So I would rather you put yes than no, because if we're putting no, we're automatically going to miss it. So if you're up in the air, should this be yes or should this be no? Just put it yes. I would rather be safe than sorry. I would rather have this patient go to a follow-up to confirm whether they have a TBI or not versus just being like, nah, I'm just going to put no. And in reality, they should have gone for a follow-up. Does that make sense? And this just outlines the actual questions, the helps, why it's called the help screening tool. So again, every week I go on site to provide medical advocacy for the shelter in Indiana. I'm there about 3 hours. All of this can fluctuate, but we wanted it to be consistent for the patients and the clients in the shelter. So if we picked one day and every set hours, they will always know that Brittany comes on this day at this time. So during this time, I'm going to make sure I stop in and see her. And we also communicate outside of just that one day a week if need be. So I can flex my schedule. I can accommodate. I'm very blessed to be in a position where I can flex my schedule like that at the needs of these clients. So, patients who screen positive are always communicated with the forensic nurse. So, if these screenings are being completed at the shelter and the shelter screens somebody that's positive, then they are going to reach out to me immediately so they can say, hey, I just screened so and she screened positive with the possibility of a TBI. So then I will then contact Dr. Kramer's office and say, we have this possible TBI. I need to get this patient in to see you for follow up. And then I work with her staff and the client to figure out a day. She likes to see them in her office within 48 hours. And she's super great about that. So she will come in early, she will stay after, she will move people around. She will see these patients within 2 days as long as it's not on a weekend. And then, like I said, it's not helpful for us to screen and then not offer any follow-up. And along with follow-up is resources too. I've created actually a few handouts, nothing like technical. These are just me making something up to be able to provide to the patient that will assist them in their symptoms management until they can see Dr. Kramer. So I just provide them with those handouts and we go over those and talk about them and make a plan that is doable for them. So some considerations to think about: time off. They need time off to rest, to relax their brain. They kind of need to put a pause on that brain activity if possible. It's just like your body. If you have a broken bone, sleep and rest is going to be super beneficial to you. And it's just like our brain. If our brain is injured, sleep and rest is going to help that. So we educate the patient on the signs and symptoms, on how to manage those signs and symptoms. We get them in with Dr. Kramer. Pushing through is not recommended at all. If we're trying to push through with a TBI and concussion, that can make it worse. If we are overworking our brain that is trying to heal, it's just going to cause more damage. So getting them in as soon as they can and trying our best to be able to rest and relax. So follow-up care. So once they go see Dr. Kramer, the first follow-up is within 72 hours, but like I said, she sees them within 48 hours typically. But she does, once they go in and see her, she does a full subacute neuro exam on them. She does more screenings on them, like how are they balancing, how is their coordination, how is their thinking, do they have headache, what is their sensitivity to light, sound, things like that. Once she does all of those screenings and exams, they will come back in 2 weeks and have all of those same screenings and exams completed again to make sure that that coordination, balance, concentration, all of those things are getting better. If they have all resolved before that 2 weeks, then she's fine if they don't come in, as long as the symptoms have resolved and they are no longer feeling any of those symptoms. And again, at follow-up, Dr. Kramer is the one who will give that formal diagnosis of traumatic brain injury. And that also helps these patients and clients to have some validation in the symptoms or how they're feeling, or even just to say, gosh, this assault is serious. Like, this is what could have happened to me if I didn't seek help. If I stay with this perpetrator, these are all things that can happen to me. So it validates the seriousness of the situation that they're in too. And Dr. Kramer is located in Northern Kentucky. She has two different locations. There's one in Erlanger. You can see it from our highway. I know a lot of you are not probably familiar with Northern Kentucky. And then there's one in Mount Zion as well. So you guys aren't super familiar, but she does see our Indiana patients as well. And Safe Passage has been super great, super wonderful about helping with transportation to these follow-up appointments, not just even with Dr. Kramer, but like any follow-up that these patients may need. I had a patient who actually had to go see an adult neuro, and then she had some things with her eyes. So like Safe Passage has been wonderful about setting up transportation for these patients. And if that's something that we're struggling with on how to get this patient to this follow-up, we also have different avenues that we can go down, which we haven't really had to do, I don't think, because Safe Passage is always on it. But we do have different avenues that we could go down to try to work on transportation for these patients as well. Getting them there is the focus. So however we need to do that, we're going to try and make it work for sure. So this is just something I put together. The TBI concussion protocol, I was asked to create something for the shelter staff on the steps that they needed to take. So on intake, they're doing this HELP screening tool. If they have a positive one, they're going to contact the forensic nurse. They're going to make copies of all the paperwork that goes along with the screening. And then we're going to hand them these resources, these handouts, and go through them with the client so they know what they need to do moving forward before they get in to see Dr. Kramer. And I just put these on here. Symptoms are different for every patient. So these are all the symptoms that they could be experiencing. It may get worse at one point. It may get better at one point. You may be on a roller coaster of experiencing these symptoms. But here's what part of the body is affecting these symptoms and what make it's validating again that these are symptoms that you're experiencing. You may feel them stronger at this point. You may feel them better if you're trying this. So it's all about what is best for the patient and what they can do. Tips for when they have a head injury. Obviously, again, take it easy. If they're doing something stressful or hard, do it in the morning after they wake up. So if they have a to-do list and we put those things in order from most important to least important, and then we put them in order of what's the most stressful, what's going to be the hardest, because that's what we're going to start with. We start with the hardest and end with the easiest, because in the morning when you wake up after your brain has rested during that sleep, hopefully, you should be doing those things first. So this is our TBI symptoms evaluation form. Again, nothing fancy, something I created. I sat down with Dr. Kramer, and this is what Dr. Kramer likes to have before she sees these patients so she can see the severity of the possible traumatic brain injury. I will say, when I first started doing this and we first started sending patients to Dr. Kramer, I had gone in before we started doing it just to watch her follow up with some of the athletes that she sees in the area. And their scores were these are all symptoms, and you score them on the severity of the symptom. And Dr. Kramer's forms totaled, I don't know, anywhere from like 20 to 30. I forget exactly what the average was, but it was okay. Most of our symptoms evaluation forms, our totals are 80. I had one that was 120. And when she started getting these, she was like, this is so severe. Their symptoms are so severe, which just validates the fact that we're doing what we're supposed to be doing. These patients and clients, they need this follow up care. They need this medical professional care to get them to manage these symptoms and prevent future TBIs, or to prevent the TBI that they currently have from getting worse and losing function. So these we're screening because this goes undiagnosed and misdiagnosed. They're saying these symptoms are from other things, and we're aware of that. And we just need to educate. Every time we screen is an opportunity to educate. We're not only educating the person, we're educating medical professionals, we're educating police, prosecution, we're educating advocates. The list goes on and on. But every time we screen, it's an educational opportunity. There's a high prevalence in TBIs and IPV survivors, regardless of the lack of statistics that are out there. We know this is happening. There's long-term health consequences that if we detect early, we can prevent from happening. And this ultimately is improving safety, access to care. We're raising awareness to improve the data that's out there. We want to improve the data, and we want to inform policy decisions around IPV and brain injury care. This is serious, this is important, and this is why we're doing it. It's essential for addressing both the physical and psychological impacts of intimate partner violence. And it's showing this population that there are people who care, and we're here to help you. Not only do we care, but we're also going to help you. So we have seen significant reductions in safety outcomes when we do these screenings. Because again, it's like a validation, or like a light bulb goes off in their head and they think, I'm not just thinking about these things, like they're real. They're real, and they're an issue, and they're serious. So it helps them come full circle with the situation that they're in, and then their will to want to get away from that too. So what has been the benefit since we started doing this? By doing this, it helps survivors address, like I said, not only the physical injuries, but also chronic health issues too, behavioral health challenges, substance use, substance disorders that often stem from the abuse that they're encountering in their day-to-day life. Integrated care promotes physical and emotional healing for that survivor. It educates them about their health, their rights, all the available resources that we have for them. And implementing this TBI screening in the shelters and in our healthcare settings, like in our medical forensic exams, it's been shown to dramatically increase the medical referrals and the access to treatment that our patients and survivors are getting. Because when I see them and I screen them, whether they're screening positive or negative, I'm still referring them out to other people. So not only are we doing the TBI screenings, we're getting in there, we're addressing all the medical needs, and that could be something that their primary care provider can assist in, but they don't have a primary care provider because they just moved into this shelter and they don't know anyone in the area. So that's my job. My job is to say, hey, look, there's this one, and this one. It's this far away from shelter. This one's in walking distance, or a shelter can transport you on this day. Which best suits you? So I will say we've seen a huge benefit. I believe that the survivors, I've had nothing but good feedback from the survivors from just showing that someone cares. They don't get that at first. So that's hard. But once they do get it and they receive it well, and they're very appreciative, and they take the opportunity to do all these referrals, and because they want to do better. And ultimately that's what it's about. It's about their health, their mental health, their physical health, and their safety. So I feel like it's come full circle, and we help with every aspect that we can by doing this medical advocacy in the shelters, along with the screening for the TBIs. I don't know, is anybody on here from Safe Passage that wants to speak to maybe the benefits that you guys are seeing? I don't know if Tori was able to get on.
Yep,
Because, of course,
I'm
I
here.
can tell you how great that I think my services are, but it's nice to hear from the shelter too and see if they are seeing positives from their side also.
Yeah. Hey, Brittany, it's Tori.
Hi.
So I am with Safe Passage and I coordinate a lot with Brittany. I think it's been huge for survivors that come into shelter to have Brittany conveniently available. Because even when you get into shelter, is it safe for them to leave? Do they have to load up their kids? Can they get transportation there? Having Brittany right here and them not having to go to another appointment is super convenient for them. And especially with the TBI screening, a lot of them were like, it's not severe. I have other things to worry about. I'm in survival mode right now. So letting Brittany know and having Brittany explain to them makes a huge difference for them.
Yeah.
And they actually listen to Brittany then too, because if I say she's a medical professional, it's a different perspective then too. So we love
Yeah.
having Brittany here.
And I love being there, Tori, and I appreciate all of you. The shelter works so hard to accommodate me, to accommodate the clients. So I just think we all work really well together. And ultimately, the needs are for the clients and the patients at that point. And you can't get any more benefit than that. So, one more thing that we had talked earlier that my position was grant funded. So, with that grant funding, I was tasked with creating a violence prevention task force for Southeastern Indiana. So, we do have 6 counties in that Southeastern region: Dearborn, Ohio, Ripley, Franklin, Switzerland, and Jefferson County. If you're looking for training, networking, policy development, community engagement strategies, this is your place. I want anybody who thinks that they're interested to please email me. I will give you more information about what we do. But right here, this just kind of talks about our mission and vision. Our mission is to promote safety, identify risk factors, and work collaboratively with one another just to develop effective strategies for our communities. And we just want to raise awareness and strengthen support systems for those that are affected by violence. So, not only just IPV, but anybody who's affected by violence in any way, shape, or form. We want to develop and create a shared framework for violence prevention across all 6 of these counties, and ensure consistency in our responses, our services of our community. We want to foster strong partnerships, and that can be with anybody. Healthcare providers are on there, law enforcement's on there, the cabinet's on there, the advocacy is on there, schools, community leaders, anybody. We want anybody and everybody who wants to help play a role in decreasing violence in Southeastern Indiana to please join. If we don't hear from you, it won't get addressed. And we can all pick from each other's brains and figure out what we need to do for our community and the survivors of violence and trauma. So please, if anybody is interested, let me know. I have My contact information is on this next slide. And you can call, email, anything you'd like. If you're interested in a task course, if you have any questions about traumatic brain injuries or any questions about what we do, please feel free to reach out. And I know that I'm over my limit here. So I will end with that. I want to respect everybody's time, but please reach out. I'm available all the time. So
Thank you
thank
so much. Yes, Brittany, we really appreciate you coming today and sharing
you.
all of this super helpful information. And I have dropped a couple of those resources that you had shared in the chat. So if
Perfect.
anybody wants to immediately grab those, they can. Otherwise, we will have a recording of this session up on our website in a week or two once we have everything edited. And we will also get everybody a copy of the slides.
Perfect.
If there are any other questions for Brittany, please feel free to either unmute or, pop them in the chat or send an email to the contact information on the screen. Just one more time. Thank you so much, Brittany. We appreciate
Thank
you
you.
coming.
I appreciate it. Thank you guys so much.